and reduced hearing in the left ear, but also noticed the right ear wasn't too far behind, although the right ear wasn't painful. Now, when I actually did the procedure, I started off with the patient's left ear, the more complex one, but for the purposes of this video, I'm just showing you the right ear first, because it's a bit more simpler, you could say. So this is the patient's right ear. There's a lot of dead skin that's oxidized over time. So although this looks like earwax, it's the majority of it is actually dead skin, and we can kind of know that by the glossiness. Dead skin over time, as it dies and sheds in the ear canal, it oxidizes and it turns from a freshly dead skin, a layer of dead skin that's just shedded, is white and almost translucent. And the longer that skin is in the ear, it oxidizes and it gets darker into a brown colour and eventually black. Now, some people's dead skin can crystallize and solidify and become really hard and like shards of glass, whereas other people's dead skin can become really mushy. And in this case, in the right ear, the patient's skin has become a bit mushy and sticky and almost like fudge. The left ear is a different ballgame completely. The left ear, the patient has actually developed keratosis obturans. Now, it could have been that if this wax wasn't removed in a timely manner, i.e. today, and we left it longer, she would have also developed keratosis obturans in the right ear. Now, I'm sure a lot of you are regular viewers of the channel, and you probably know what keratosis obturans is. But if not, I will explain it a bit later when we do the left ear, because there's going to be a lot of time for me to discuss that in depth, because it's a long procedure in the left ear. Now, with children, if you watch, I'm doing loads of paediatric cases recently, I'm getting more and more referrals. Now, with this patient, they have tried to see other specialists and they just found it too difficult. One, being a child, and two, it is a difficult case. They just keep being advised to use drops and drops and drops. In the case of the left ear, they've been having their symptoms for about a year, and I'm surprised, they were able to tolerate that level of pain. I'm guessing, obviously, it was intermittent and it subsided and it improved over time. But with children, naturally, they've got very small ears. You can just see there how narrow that ear is. I can just about get the suction probe in. I'm slowly but surely, you can see these movements I'm using with the suction probe. I'm trying to detach the outer layer of skin. You can see that skin's enveloped the plug of keratin and wax. It's attached itself to the canal wall, and I'm just gently wriggling it left to right, up and down, just to bring it forwards. It's a hell of a lot of amount of wax. This is, I think, the last piece. Now, what's very unique about this patient's ear, you'll see it in a moment, I believe, after I remove this plug of dead skin. She's got extremely narrow, bendy ear canals, and it's so bendy, I can barely see the eardrum. So we're just going into the ear. This is the isthmus, the narrowing, and you can just see the eardrum to the right. I can just about with an endoscope twist it and manipulate, but she's got probably the most... Actually, I've got one of the clients who's actually got even a twistier ear than this patient. And that could, in some part, explain why this patient's experiencing a build-up of wax, because of those bends and twists in the ear. The wax is or the skin, should I say, it's naturally trying to migrate out of the ear, but as it's travelling around the bend, it's getting trapped, and then you're getting a build-up behind it. Now, this is the left ear. Now, this is the one that's causing the patient problems, and immediately, I kind of knew this is more than just soft dead skin. This is keratosis obturans, and the patient is very anxious on this side. You saw that I came out a moment ago, and that's because even before I kind of went in the ear, the patient made a little kind of noise like to kind of emphasise that she found it painful. So I actually paused the procedure at that stage, and I played the video back, and I just reassured the patient we weren't entering the ear, so there's nothing to worry about at that stage. And I suspect it's more the patient's, assuming it's going to be painful, a bit psychosomatic. They're already in severe earaches. Remember, this patient is only 11, and kudos to her, because the way she handled the procedure is absolutely amazing. So she's only 11, and she came in with a very severe ache to begin with. And I'm just trying to testing the surface here, and every time I make contact with the surface of this plug, and it's a lot harder and crustier than the other side, the patient's experiencing a bit of pain. So I'm just going in with the ear hook, trying to embed it. Remember, again, she's only 11, the ear canal is really small, so we're limited in space. I'm just trying to find a way of manipulating this, because the surface of this plug of dead skin, this keratosis obturans, it's so solid. I can't get through it in any way. There's no suction grip. The plug is too much expanded against the canal wall, so it's adhered itself to the back part of the ear canal in particular. So I just put some drops in. I'm just suctioning out the drops at the moment, and then I'm going to the back part of the ear canal. And what I'm trying to do is gently massage this away. I'm trying to lift it off the canal wall. She just found that painful again, unfortunately. So I'm just having a look, trying to think about the best angle of attack. And I've just gone back in with the ear hook. And I'm just trying to... Now, again, she found this quite painful, but just kind of, whilst I was doing it, I was just reassuring her that we're not too far in the ear, we're just kind of halfway into the ear canal. And I managed to bring some forward, you can see. And I was hoping, as I was bringing this forwards, that I'll get all the plug out in one go. Little did I know, that wasn't to be the case. So I just went back in with the hook. I'm just trying to dissect this piece of skin away from the main bulk. And again, with this patient's left ear, it's also quite bendy and twisty. It's got a big inclination going upwards. So I'm just embedding the ear hook again. Again, she's finding this slightly uncomfortable. At the same time, I did advise the patient, if it's too uncomfortable, do let me know. Sometimes in cases like this, it's not uncommon for ENT to perform it under general anaesthetic, so the patient's asleep. I know a couple of cases where that has been the case with some ENT consultants that I work alongside. And I did kind of suggest it at one stage as well. Is it such an impaction? That might be one option, but patient wanted me to continue because she just wanted this out of her ear. And she didn't, as I said, I made reference to earlier, she did amazingly well. Hats off to her, she's very brave. So just back on the back part of the ear canal, you can just see how, you can probably see this plug of dead skin now, it's expanding the ear canal. So I'm going to explain what keratosis obturans is. Now, everyone's ear canals are lined with skin, and even the outermost membrane of the eardrum, so the eardrum has 3 membranes, the outermost membrane that's facing us is also a layer of skin, the same skin that lines the inner 2/3 of the ear canal, which is an epithelial, an outer layer of skin. In most people, as this skin dies in the ear and it sheds, it naturally moves sideways like a conveyor belt out of the ear. If it didn't, then everyone's ears would be blocked full of dead skin, i.e. like this patient, and this skin, you'll have another layer of dead skin and another layer sitting on top of the previous layer, and it'll form a plug, and this plug of dead skin will just get bigger and bigger and bigger, and it'll widening, wider and wider in the ear canal, and the pressure, the force can be so great by this growing plug of dead skin, it can start expanding and widening the ear canal, and that's what's happened in this patient's ear. And we call that keratosis obturans. So keratosis, it's Latin for keratin. So keratin is a protein that's found in dead skin. And obturans, I'm assuming, without checking the dictionary, it's Latin for obstruction. And when it widens, it can permanently distort the shape of the ear canal, typically in the bony part of the ear canal. And you'll see once I've removed this plug, unfortunately, this patient's bony part of the ear canal is much wider than the other side. It has expanded. And once you've got an expansion of the ear canal, it's very likely that the patient's going to have this procedure performed regularly, because fresh layers of skin, as it migrates out of the ear, it will get trapped in that widening. It can't migrate out of the widening, and then you'll get another formation of a plug. So I'm just using a little ENT needle. So it's not a Cawthorn hook here. It's actually an ENT needle. Now, it's what sometimes ENTs use to position grommets into the eardrum after they made an incision. And I just want to see if I can disrupt this a bit. So you've got to be really careful. So this has got it's not like an ear hook. It's not got a 90-degree bend. This is a very sharp tip, and you're going to be really, really careful not to make contact with the ear canal with that. So I've got this ball of keratin out, and I couldn't use that instrument anymore because it's all on the edge now that I'm trying to peel off. So at the base, this is where the ear canal is expanded. So I'm going with the suction probe trying to lift the skin. You can see this is a fresher layer of skin on the periphery, on the outer part of the plug. And the core of the plug is, you can see it's oxidized, it's really dark. And again, just to remind you guys, it is an 11-year-old child, very narrow ear canal, so that alone makes it more difficult. So I've just put, because I've lifted this skin up, I've just put some sodium bicarbonate drops in. Sodium bicarbonate is much, much better with dead skin compared to olive oil. Olive oil drops doesn't really soften dead skin, whereas sodium bicarbonate does have some effect. Now you can see the angle and the trajectory and the anatomy of this patient's ear. It goes up quite a lot, 45 degrees up and also to the right, and then the ear canal straightens a bit. This is this patient's second bend. I'm just trying to lift this up out of the expansion. So because the patient's ear canal is expanded, we need to get this out of the expansion. So I'm just really, really lifting. It's a lot of, unless you're performing the procedure, it's hard to kind of understand how much pressure I'm putting here at the same time. And again, the patient did find it a bit uncomfortable, but it was tolerable for her. And again, I did ask her if she wanted me to stop, and she just said, no, please carry on. So, and I don't know if you can see the expansion. So you can see the rim of the ear canal, and where I'm lifting the skin, it's revealing the ear canal underneath that, and that's widened quite significantly because of this keratosis obturans. So I'm just trying to lift out the widening up posteriorly as well. And again, I'm going to lift this and put some more drops in. And the drops will just soften this a lot more because it is extremely hard still. And I'm just moving to the front part of the ear canal, trying to lift out the widening there. Now that I've got a bit of a suction grip, I'm just wriggling this, trying to bring it forwards and out of the ear. And with keratosis obturans, if you watch, I've got a whole playlist dedicated to keratosis obturans on my channel. It is a patience is a virtue with this. There's no shortcut, especially because many of the patients, one of the hallmarks of keratosis obturans is ear pain. Quite often you get people really blocked ears with earwax, and it's not painful for them, but most people who attend with keratosis obturans, they do experience pain or talgia, and that's because this plug is expanding in their ear, and you can just imagine something like keratosis obturans. For me, the texture is similar to a rubber ball. It can be really springy, and it has loads of kinetic energy. You've got a rubber ball in your ear, and it's getting bigger and bigger, and it's really deep. You can just kind of imagine how uncomfortable that can be. So what I've done, I've really trying to lift this dead skin off the canal wall. I've put loads of drops in, sodium bicarbonate drops. And what I'm going to do is suction this drops out in a moment. So you can begin to see the widening here where we are. So I've lifted all this off the widening. And what I'm going to do now, I'm just trying to maneuver this plug of dead keratin in such a way where I can then use some forceps to see if that helps. And you'll see me use some forceps to good effect in a moment. I wasn't able to really use forceps prior because there was nothing for me to pinch onto. With forceps, you need something to grab onto. And you can't make contact with the canal wall with forceps. So it's not a case of sliding the forceps against the canal wall, because that would be really uncomfortable. And like I said, the patient was already suffering from earache. And I think this is the moment where I thought, I've got something to really grip onto. Again, the patient did find it slightly uncomfortable at this stage, if I remember correctly, because I was actually feeling this moving forwards. Now, I've had nasal packs inserted up my nose before, and when the nurse removed the nasal packs, it was probably the worst feeling ever. I wouldn't wish it upon my worst enemy. It's almost like she was pulling my brains out through my nose, and I suspect that's what the patient was experiencing as I was bringing this plug of dead skin forwards and out of the ear. You can see. And the problem with forceps, sometimes it doesn't come out in, comes out in little ribbons. It doesn't come out in a big plug. But nonetheless, the forceps did help quite a lot there. So again, I'm just trying to peel some of this off the canal wall. And we got a bit of plug of keratin here, and I can just use suction here just to wriggle this forwards. I think I'm going to go back in with the forceps in a moment. Now in the distance I can start to see the eardrum now, but just like the patient's right ear, the eardrum was almost hidden from view. The ear canal was really bendy, and inferiorly, so when we say inferiorly, we mean to the bottom of the eardrum, there was a huge cave. Now, we'll appreciate that in a moment when it comes in view. So the bottom half of the eardrum, you can't actually visualize in this patient because the ear canal near the eardrum suddenly slopes down. It's like a ski slope. And I have a feeling possibly, so this could be, it is going to be a chronic problem for the patient. So they are going to have their ear canal regularly cleaned of this dead skin, but it may be in the future when the patient's a bit older that if it can't be managed conservatively via regular cleaning, this dead skin formation, that she may benefit from surgery, I feel. And obviously that's an ENT decision where they actually widen the ear canal and almost straighten it near the patient's eardrum at the base, because so there is no trench there. It's probably the biggest trench I've seen in someone's ear canal near the eardrum, where so much so where you couldn't actually visualize beneath because it just takes a big dip, and that might help with the natural migration of skin. So we can see the eardrum in the distance there, but this last piece of skin, it took me about 10 minutes and I didn't get all of it out. If for those people that don't like it when I don't get everything out, which sometimes it's just not possible, I'll just pre-warn you. But this last piece of skin is so embedded. Now at this stage I can't use forceps because the tip of the forceps is pointed. It's like a dagger almost, and because this skin it's actually on the eardrum, so for me to get the jaws of the forceps around this and then get a grip, the distal end, so the tip of the forceps, is going to poke into the patient's eardrum and it'll be extremely uncomfortable. Now, we're now working within, as I said, right up to the eardrum. This is the isthmus now. I don't know if you're on the left-hand side where I'm working, you can see the skin, you can see the ear canal. So that's a natural narrowing that all of us have in our ear canals to different degrees. And then after the ear canal narrows, it widens again. And it's this widening that causes a recess. It causes a recess inferiorly, so to the bottom of the eardrum, and also anteriorly. So anteriorly means to the front part of the ear canal. So in the case of the left ear, that's the left-hand side. So this skin, I'm just trying to peel it posteriorly, but it's so strongly adhered. It's really, really difficult. And this is inferiorly. This is where the patient's ear canal suddenly drops over this. So this is like almost like, think about Mount Everest, what you can see at the bottom of the ear canal, and it's a huge decline in the ear canal, and that's where this skin buildup is all originating from. I feel this skin is all originating from the patient's eardrum, and as it's trying to migrate off the eardrum out of the ear canal, it's getting trapped in the basin, and then from there you're getting more dead skin, and it's forming a plug, and this plug has to get so big it's coming outwards, it's protruding out towards the entrance of the ear. And once we complete the procedure, you'll see the patient's complete eardrum, this top part of the eardrum, so it's the superior aspect. You can see the hammer bone. We did do a pressure test, a tympanometer test, which assesses the mobility of the patient's eardrum, and the eardrum was vibrating fine, but there is a bit of dead skin on the eardrum, and it wasn't safe to continue because it was completely stuck, and I didn't want to perforate the eardrum. She was hearing significantly better. Her symptoms had improved. I've advised the patient's parents to make sure they install sodium bicarbonate drops. As I say, sodium bicarbonate drops is far more effective with dead skin formation than olive oil. Twice a month, and really dose it. So we've asked them to lay the patient down, so their left ear, this is the left ear, is facing the ceiling, to instill the drops, really fill it up to the brim, leave it for 5 minutes, and after 5 minutes ask the patient to tilt the head the opposite way, so the left ear is then facing the floor, the ground. Place a tissue beneath the ear to trap and collect all the drops as it's coming out, and that will kind of soften any dead skin, and any remnants that have been softened to a point where it's then loose will drizzle out the ear alongside the drops. So again, I just want to go to the back part of the ear canal just to see if I can peel this forwards and off the eardrum, but it's so stubborn. I'm using a fine end suction tip here, gauge 18. Be really careful because there's just the eardrum just behind the skin and there's hardly any room for me to manoeuvre. I describe keratosis obturans like this near the eardrum, almost like chewing gum. It's stuck chewing gum that's dried out and it's strongly adhered itself to the bottom of your shoe or your clothing or something along those lines. It's one of the hardest things to remove. So I've just gone back into the anterior recess because this patient's also got, just like, remember the patient's right ear right at the beginning, how bendy it was, and the right-hand side of the eardrum was hardly visible. It was hidden away because the ear canal was so bendy. And it's similar to here. So to the left here, on the left-hand side of the canal, there's a vicious bend to the left. And that's where the eardrum is also sitting. So I've just got to be careful not to make contact with this canal wall. So I've bent my suction tip a bit and I've just got a bit of keratin out there. Okay, we can just start seeing the hammer bone now. So slightly to the left, to the left of the suction probe, you'll see a red landmark on the eardrum, and that's the patient's hammer bone. Now, normally, if it's a bit of a straighter ear canal, I would be looking straight at the hammer bone right now. But this patient's eardrum veers to the left. Again, this skin is so stubborn. So the patient can, at this stage, can now hear very well because the eardrum is visible, sound can get through. I'd probably say the patient's ear canal drops. Where I am now, it probably drops about 0.5 centimetre further down. It's such a steep drop that we just can't visualise that. So if you remember before, I said this patient may possibly benefit from surgery in the future, and it could be that a surgeon uses almost like a bone scalpel, and where we are now kind of almost drills this out, widens it, or kind of scrapes it wider so we can see the bottom part of the eardrum. So I just put some more sodium bicarbonate drops in. I think we've put some sodium bicarbonate drops at least 4, 5, 6 times, I think, so far. So you can see I just got some more keratin here from the inferior recess. And we are right on the eardrum now. This keratin has well and truly settled itself, so I'm just going to be careful. So you can see more of the eardrum now where I am there. And I've actually bent the tip of the fine end so I can get into the inferior recess. So we're seeing more and more of the eardrum now. So we can see most of the eardrum just at the bottom. There is some keratin, but I just can't get access. Although I am trying again. So I got a bit more off there. think I've decided to stop in a minute because it was becoming a bit uncomfortable for the patient. I feel like I went beyond what I was going to achieve today, and sometimes we quit whilst we're ahead. We try not to be silly, and after all this kind of the patient sat so still for us as well. We've done all this amazing work that we end up causing her trauma or perforating the eardrum. It's just counterproductive. We've got one more stab at it. Let's have a look. You can just see the eardrum move there a bit. I think I actually managed to get this keratin out, or at least in part some of it. I will annotate at the end of this video where the hammer bone is, because obviously it's so difficult to visualise the eardrum because of her anatomy. And we're only seeing the top part of the eardrum. The bottom part of the eardrum is completely out of view because it's below the canal where it steeps down. So we're not able to see the bottom part of the ear canal. No doubt this is what's causing the patient her keratosis albicans. This skin just can simply not migrate out of the ear because it gets trapped in this pocket. I think I've just bent my suction tube down trying to get inside this pocket. And that's the back part of the patient's eardrum, what we call the posterior quadrant. I think I'm actually stood up at this stage trying to look down into this cave. You can see I've angled the suction tip downwards just to see if I can get into this cave safely. I've managed to get a bit more keratin, I think. And there we are, guys. So this is a still image. I'm just going to annotate over it for you. So we're just more or less seeing the top part of the eardrum. The bottom part of the eardrum is where that bit of skin is at the base. So the ear canal steeps down. To the left, where I've labelled it, we've got the hammer bone or the handle of the malleus. Typically, more of a straighter ear canal, that would be more central to the right. But so this ear canal bends to the left. To the left, we've got the anterior recess. So sound can get through, so the patient can hear. As I mentioned, preventatively, we ask the patient to use sodium bicarb drops on a regular basis, and we're going to monitor the patient, but it could well be that when she's a bit older, she will need to have surgery just to kind of carve out the bottom of the canal a bit, so it's a bit... we can see the bottom part of the eardrum, and the skin may be able to naturally migrate better.